Thanks, Nihat. So Nihat started the recording now.
Just a couple of comments in the chat box. Some people that can't hear because they've been muted, which the muting obviously doesn't impact on your ability to hear, but two people, it's Elizabeth that's struggling. I did suggest just to log off and then log back on, and Jeanette, but others have been saying that they can hear. So Jeanette is going to leave and try and rejoin. Hopefully that sorts it.
Thanks, Raya.
For her.
Yeah, the mic's disabled, but that shouldn't impact being able to hear at all. So yeah, I'd agree. Try and hop off and hop back on again. We did that with Katie and Ruth, and it seemed to fix it, didn't it, when we couldn't hear you? So we'll just wait another minute. So should we make a start? I make it 12:30 now, and just want to say hello and welcome to our Supervision, Accountability and Delegation webinar. Can I introduce myself if we haven't already met? My name is Gabby Ford and I am an AHP Clinical Fellow working on the National AHP Support Workforce Programme. Next slide, please, Kim. So on to usual housekeeping before we start. Are you able to move the slide, Kim? Brilliant, thank you. So this webinar is being recorded so that we can make it available along with the slide deck, which we'll upload to our web pages afterwards, which we've done with all of our webinars. If you haven't found your way to our web page yet, don't worry. The link to the web page is at the bottom of this slide. As you've probably already guessed, your audio is disabled, but your cameras you can switch on and off. But to ensure that we do get a good quality recording with no interference and no issues with our presenters in terms of broadband, can we just ask you to switch your cameras off at this point, and we will do as a presenting team as well. The chat box and your reactions are enabled, so please do put any questions or comments in the chat box and we can answer those as we go along. We've got a good 20 minutes allocated nearer the end of the session for Q&A with our speakers, so we'll be able to open up those questions if we've not been able to answer them as we've gone along. And I know that professional body colleagues are also on the call and will also input where appropriate. If you do want to get in touch via our generic email, you can see it on this slide. Please do, we'd be more than happy to answer your query. And for those of you on Twitter, it'd be great if you could use the hashtag AHP support workers to raise the profile of today. This webinar is an hour and a half long, as our other ones have been as well, and it's over lunchtime, so please do change your posture and position when you need to, and feel free to eat your lunch and grab a drink when you need it. And then finally, we will be using Mentimeter to gain your feedback. So we're going to ask you to do that now, if that's okay. So if you could get your phone out or another device and go to Mentimeter now. So it's menti.com. And if we move on to the next slide, you'll see the code or the QR code to scan. So can we go to the next slide? Lovely, thanks, Kim. So if you just simply scan this QR code, it will take you straight there. If you can't do that, go to menti.com and input that code that's on the screen now. And I'll just give you, it's only one question. I'll just give you a couple of minutes to do that now.
Gabby, quite a few people are saying in the chat they can't hear, just to let you know.
So I think that's probably going to be your end rather than our end. Okay. If you just leave and then join again, then hopefully that will be sorted out. If you're struggling any other way, then I think let us know Generally, that should sort it out though. Thanks, Anne. If we could just keep cameras off, that would be great. We've got fantastic number of people on the call. I think we're at 800 now, which is absolutely brilliant, but it might just cause broadband issues if we have cameras on. Thank you. Thanks so much. Just give you another 30 seconds to complete that Menti. Okay, so as you can see from this slide, here's our exciting agenda for this lunchtime. Really looking forward to hearing from all our speakers, and a huge thank you to all of them for taking the time and preparing this session for us. As you can see, we have a clinical scenario from Katie and Ruth, showcasing what good clinical supervision, accountability and delegation looks like. And then we've got Kim from the HCPC and Anne Keane from the Royal College of Occupational Therapists, providing us with guidance and support around HCPC standards and AHCP, an AHP professional body, and their support. Sharon is going to spotlight what good looks like locally from an organisational point of view, and then we have some time, as I've already mentioned, for Q&A, and I'll wrap the webinar up with our next steps. So if we can go on to the next slide, please, Kim. And then this is what we're covering for this lunchtime.
Sorry about the slight delay, Sharon. The slides.
Lovely, thank you. So what we're covering today, what we hope is that by the end of this session, you will have a better understanding of these key areas. So we hope to give you a better understanding of what good clinical supervision, delegation and accountability looks like for all our AHP support workers. And we'll be hearing from Katie and Ruth showcasing this in practice. We hope to give you a better understanding of the organisational policies and processes that enable safe and effective delegation and what good looks like locally. And we hope to give you a better understanding of the wider governance, such as I've already mentioned, the HCPC standards, and crucially, the support and guidance from our AHP professional bodies. Next slide, please. So before we hear from Katie and Ruth, I wanted to briefly do a bit of context setting. So recapping, and the next slide as well, please, Kim, our AHP support workforce sort of overall programme aims and why we're doing this webinar. So here are the programme aims that we're trying to accomplish, which we're well on our way with. And you can really see how good, effective and safe clinical supervision and delegation really does underpin these aims. I'm not going to talk through them today, as I'm sure you're all aware of them, but it was just to point that out and signpost you there. Next slide, please. And I also wanted to ground us all in our aim statement for this programme of work. So our aim is to have consistent, occupation-specific and sustainable education and career development pathways for all our AHP support workers and real fair opportunities to access this. And this to be implemented by services across England by April 2024, which actually isn't that far away now. Fast creeping up. Next slide, please. And then on to why we're doing this webinar. And there are key reasons why. First and foremost is that we're doing this as a response to queries and requests that have come into our team from multiple stakeholders from across all our AHP professions. The word cloud that you can see on this slide is the identified learning needs from our 207 NHS providers and their reports, which were submitted at the end of last financial year as part of the Workforce Supply Implementation Strategy project. And you can see both clinical supervision and clinical delegation have been identified as learning needs. We identified it as a programme priority, and as part of that work, we have commissioned a stakeholder engagement project in the Northwest, which will be completed early next financial year. And then thirdly, we have completed a literature review and we'll be publishing a curation document from this early next financial year. And this did reveal that there is a wealth of resources available, but it was quite clear that this was not always translating for frontline staff, and there was a bit of a disconnect. And we've also been working collaboratively with the HCPC and all our AHP professional bodies, who you're going to hear from really shortly. Next slide, please. And so now I have the pleasure to introduce Katie and Ruth, who are going to talk you through one of their everyday examples of delegated activities to Katie, a support worker, and Ruth, a registered speech and language therapist. Next slide, please, Kim. Ruth and Katie, over to you.
Thanks, Gabby. Good afternoon, everyone. First of all, I'm just going to apologise briefly because we are having to share a microphone set between the two of us. So my name's Katie Betteridge. I'm a Band 4 Senior Therapy Assistant at the Queen Elizabeth Hospital in Birmingham. I work on the burns unit and my job role is split across 4 of the AHP disciplines, so occupational therapy, physiotherapy, speech and language, and dietetics. So I'm just going to hand over to Ruth.
Hello, good afternoon, everyone. So yeah, I get to work with Katie and I am a senior speech and language therapist here at the QE and I cover burns and also critical care.
So we were asked to put together a case study of my day-to-day really. So we decided to highlight my role within speech and language. So my day-to-day consists of working with the 4 AHPs. On our unit, we have 15 patients, and as Ruth said, we also cover ITU. So part of my morning is I attend handover with predominantly the physiotherapists and the occupational therapists. And then what happens is I then liaise with the speech and language team and the dietetics, either via email or telephone call or face-to-face. So on the slide in front of you, you can see that this is a therapy MDT handover. So this is just, you know, my standard day-to-day. So the patient handover we've got in front of us here is Janet, who is a 46-year-old female. You can see her date of her injury, and you can see when she attended hospital. So she sustained 75% total body surface area. So what we mean is that is a percentage of the body that has been burnt through injury. She also sustained an inhalation injury. So for those who don't know what inhalation means, that is someone who has breathed in smoke, gases, or any toxins during the mechanism. This was done through a house fire, and you can see her past medical history is depression, MS, and while she's been on the unit with us, she was decannulated. So this was a patient who had a tracheostomy and they've basically removed that. So the physiotherapist in blue, you can see, has asked me to complete range of movement exercises with this patient. The occupational therapist has kindly asked if I can complete some daily orientation with another patient called Sid. Ruth has kindly asked me if I can complete mouth care, swallow rehab, therapy supporting meal times, and if I can complete some voice exercises, which is called Lax Fox. And the dietitian has asked if I can complete a weigh-in for the patient and complete food charts. So looking at that handover there, we can identify that my main priority for the morning is the therapy supported meal time at breakfast. If you go on to the next slide, please, Kim. So this would be the priority of what I need to do first of all for my day-to-day. So how I work with my list and my prioritisation. So within my team, we work on a traffic light system. So if you think red is most important, amber is someone that's ongoing with their therapy, so they're an ongoing rehab, and a green is usually when the patient's been discharged from my caseload. So how it works is Ruth has kindly handed over to me that this patient needs therapy supported meal times, particularly at breakfast. So what I would do is I would read through the patient's noting. I would look at what the speech and language therapists have done with that patient already. I will have a look at what it is that the patient's trying to achieve. So the speech and language therapist will put what their plan is, what their previous assessments were with that patient. As you could remember from the previous slide, they also asked if I could do something called a lax fox, which is something that wouldn't be within my scope of practice. So that is something that I would feed back to the speech and language therapist. Following the assessment, I would then document that on our on my entries, and then I would also feed back to the speech and language therapist and the nursing staff what it is that I've done with that patient and report back, so we've got an ongoing plan going forward. Next slide, please, Kim. I'm just going to hand over to Ruth.
Thank you, Katie. So from a speech and language therapy perspective, we need certain assurances to make sure that we're supporting Katie in the best way, and that also we know that our patients are getting safe care from Katie. So as part of our induction process here at the Queen Elizabeth, we will complete some formal competencies with our Band 4 SLT assistants. And this starts off with an induction. So Katie understanding more about our role as speech therapy, what our goals are, what we aim to provide to our patients. And in doing the induction as well, she'll also get lots of shadowing opportunities to see the types of patients that we might come up against and how we would approach the management for these patients. We then get to complete a set of specific competencies for each banding. But again, like Katie's already mentioned, we need to make sure that this is within her scope of practice and competency. So we'd want Katie to escalate to us anything that was outside of her competencies or scope of practice. It's a bit of a two-way street. As therapists, we shouldn't be asking more of our support workers than they're competent to do, but it's also good to have that safety net that Katie is aware of what she can do and what things might be out of her scope. And it might be that this also highlights that there's more learning needs and things that we can get involved with and do some more joint working. So we're fortunate enough that we do quite a lot of joint reviews. It might be that the first time we're seeing a patient, we see them together. Katie's made aware of what the plan is, the therapy that we want her to complete, and then going forward, Katie can complete that independently. It's really important that she's aware of how to escalate any concerns to us. So we're quite accessible. Being in a large acute hospital, there's always somebody around. So any concerns can be escalated via our bleep or face-to-face discussion on the ward. And we know that Katie will escalate any concerns to the nursing staff there and then. Documentation is really important for us. It's a legal document, but it also helps us to have a record of the input and the provision that we're giving to patients, so we know that we're delivering good quality care. And it also allows us to check in to make sure patients have been seen, and if there are any concerns that might change our plan in terms of next steps. And I think that's the real value of Katie's role, in terms of Katie can go and see a patient, put a plan in, feedback to us, and then it helps to plan our ongoing steps and goals with this patient. Other assurances that we have are supervision. So Katie has access to all disciplines that she works with, so it won't just be speech therapy, it'll be OT, dietetics, physio, and we all have that responsibility to provide supervision to Katie. This can be done formally at our 6 weekly supervision sessions, but also tends to be done quite ad hoc on the ward. So we get that initial feedback, a bit of a debrief in terms of how the session has gone. And Katie knows that she can always come and find us if there's something that she wants to talk through as well. And as you say, get regular MDT input with the formal one-to-ones, and also participation in our in-service training sessions. So Katie has set up in-service training for our Band 4s here at the QE, but also giving her the opportunity to come to our discipline specific, so our speech therapy in-service training as well, to sort of provide that extra clinical supervision as well as the sort of day-to-day supervision. Next slide, please.
So following the outcome of the assessment, so part of my role working within the 4 AHPs, I don't just, take into consideration the therapy setting in terms of like swallow rehab and things like that. I'm looking at the whole, the patient as a whole, really. So assessment of environment. So is the patient sitting out in the chair? You know, do they have the dentures in place? Have they got the glasses on? Are we mindful of noise? You know, is there any disturbances that the patient might encounter, any loud noises, things like that? Do they want any music on in the background? Making sure that I'm working alongside the healthcare assistants as well to ensure that food record charts are being completed, as we know that the nurses across most of the hospitals are very short staffed. So it is just making sure that they are having that support and encouragement as well to make sure that these record charts are being filled in. Oral care is something that we do as well, so making sure that the patient's mouth is clear, there's no secretions, there's no food gathering within the patient's mouth, so making sure that oral care is being completed. And again, this is something I can do alongside the healthcare assistants and the nursing staff. Again, when it comes to swallow assessments, and the reason they asked me to do this particular assessment in the morning is to making sure that they're not at risk of aspiration. So they're not choking on any of their food or bringing anything up, and making sure that they are able to enjoy their meals and that they are getting their nutritional supplements, which is really important for our burns patients. Again, feeding back to the nursing staff and to senior registered staff as well. So I would always report back to Ruth to discuss the outcome, and then I would document it on our therapy noting that we all have access to, including nurses. And yeah, feeding back to speech and language with regards to the voice exercises. Again, this wouldn't be within my scope of practice or competencies, but definitely from a learning point of view, I mean, I'll always go along with the speech and language therapist to just see what they do with these particular patients, just to gain some experience, and as I say, for my own personal development, just to shadow and see what the guys do, because they do some amazing work, as you can imagine. Thank you, Kim. So that is it from myself and Ruth. So we're going to hand over to Kim Tolley, who is the Interim Head of Professionalism and Upstream Regulation. So thank you, Kim.
Kim, I think you can unmute. Can you unmute yourself? Won't let me do it.
There we
Yeah,
go.
thought so.
Sorry. Myself and Anne are going to do. Does that sound? Yeah. Okay, sorry. Myself and Anne Keane are going to do the next part of the session, very focused on the standards and professional body. I've got some feedback. Does that sound okay to you? I think it probably does.
Yeah, sounds fine.
Perfect. So we thought we'd look initially at what the health and care professionals say about delegation and supervision. And then Anne's going to move on to what the professional body says about supervision. So first of all, I'm going to look at what the role of the HCPC is. Just briefly, we obviously write standards and publish a register of healthcare professionals who are registered, but we also set standards for them as part of what they have to follow in their day-to-day work. And I think it's really important that we sort of think about what we say about delegation. So we write the standards of proficiency, standards of conduct, performance and ethics, and the standards of continuing professional development. And the first one is about standards of conduct, performance and ethics. And delegation is standard 4. So that's quite good, isn't it, really? Sorry, I've just highlighted that. And it's really important as a registrant that you only delegate work to somebody who's got the knowledge, skills and experience, as we've heard. I thought they were really good case study because it showed what could be delegated to Katie and what couldn't be delegated to Katie. And as registrants, we have responsibilities. And I think it's really good to share those responsibilities with everybody. And we've obviously got responsibilities to find out if the support worker is competent, and that they have the knowledge, skills and expertise to undertake that skill and undertake that task. But when we pass on that delegation for that task, it's important that we know that we're also responsible for monitoring and supervision of that person, just exactly what was described. So that's really useful. So delegation is about asking your colleague to provide the care. And of course, we all have to delegate in clinical practice, but we only delegate within the person's scope of practice. And as I said, we need to provide appropriate supervision and support. So Anne, I'm going to pass over to you. You're going to look at what the Royal College of Occupational Therapists says about delegation.
Thank you. Thanks, Kim, and hi, everybody. Just to introduce myself briefly, so I'm Anne. I'm an occupational therapist and HCPC registrant, and I run the Professional Practice Inquiry Service at RCOT. And a lot of we support our members with issues related to their practice and any questions they have. And I'm sure a lot of the delegation and supervision questions that we have, a lot of you would recognise, because obviously all of us as AHPs, we all have to follow the HCPC standards. So a common inquiry I would get is from an occupational therapist who would ask, can a support worker do, and a variety of examples. So it might be, can they do an assessment? Can they cover a ward? Can they order equipment? Can they write up patient notes, etc., etc.? So you name it, people will ask about it. And so the principles are going to be exactly the same as Kim has stated, and also earlier with the real life clinical examples. And often it can help with, so we have our professional standards of conduct, performance and ethics as well that are very, very closely linked, of course, to the HCPC standards. And the standards are meant to be used, they term it OT personnel, so occupational therapy personnel, so that it's not just for occupational therapists, it's for support workers, for students, apprentices, any practitioners who are working in management or leadership, education, research, advisory roles, etc. So you can use the guidance and the standards across the board. Next slide, please, Kim. But suspenseful, isn't it?
Yeah, sorry about the slight delay.
Okay. So, again, what we say about delegation to support workers. So, any task can be delegated to them, but however, the delegating practitioner retains responsibility for the task that they delegate. They must make sure the person's competent and they must provide supervision and support for them. And what I particularly like and appreciate and value about this is that the part of you can leave it there, that's okay, Kim. So what's important is that the responsibilities of the delegating practitioner, so I know we know this, but we can't just dump things on support workers, or sometimes they might have a manager who's from a different background and may not appreciate the importance and the responsibility of delegating a task. So that's really important, and I reiterate a lot of that with people, is we can't just say go and do that. We retain responsibility for that. And also the importance of us being able to ensure that somebody is competent as well, as much as we possibly can. So obviously you would hope that that person, their skills, also that the person feels you've got a very good professional working relationship, so they feel able to say if they're not able to do a task, or if they want support, if they want guidance, and so that person doesn't feel dumped on. They feel that it's very much a team way of working, and that obviously the person that they're working with, the patient, the service user, is at the centre of everything. So in our professional standards, it sets it out similar to HCPC. So again, I won't read them word for word, but it's about people being competent. It's about us providing appropriate supervision and support, is the way that we term it in the RCOT professional standards. So that can be both formalised supervision, but also supervision, constant informal supervision as well. And this is a really important one that people don't realise as well. So, for example, the last point, 6.5.3. So if you're, for example, an occupational therapist who's delegating to another occupational therapist, maybe you're band 6 delegating to a band 5, even though that the band 5 occupational therapist is an autonomous professional and they're responsible for their own practice, it's still the responsibility of the delegating practitioner to retain that accountability. And I think that's that's really important to have that awareness. Next slide, please, Kim. So next slide as well, please. So linked to that, we're going to talk about the link between supervision and delegation that we've already touched upon. So within our supervision and delegation guidance, it talks about this appropriate supervision. So what does that mean in practice? Next slide, please. So if you're a member of the Royal College of Occupational Therapists, we've got a supervision guide that you can download. And also, if you're not a member and you would like to purchase a copy, you can do that. As you can see, it's from 2015. So at the moment we're reviewing the guidance, but I really love this document, and I use it all the time with people who are got inquiries or asking about supervision and responsibilities, because it's really well laid out and it's really easy to understand. And what we've also recently done at the college, and if you're an OT and you remember, you may have received this, we've done a really large membership survey, supervision survey of our members to find out exactly what's going on in reality in practice. And we've got a lot of follow-up work we're going to do regarding that. Next slide, please. Thank you. So this is from the supervision guidance itself, and it talks about supervision and delegation together. So if you're in a supervisory or leadership role, then we all need to be aware of our responsibilities in relation to delegation. So when the delegator asks or instructs another person to carry out the interventions or any other procedures, they should be satisfied that the person to whom they're delegating is competent to do so. And again, it says about the responsibility to the delegating person. So they're responsible for that ultimate care that's provided to the service user. Next slide, please. Okay. So this is easy, obviously, to write down on a slide, but it can be difficult. It can be a challenge to do in practice. But the supervisor and delegator needs to judge the level of supervision that is provided while the person is carrying out the task, and it depends upon that person's ability and level of experience. So it's the delegator's responsibility to monitor the activity and the outcomes, and this includes ensuring that care records are fully and accurately kept. So again, this is to protect the support worker from just being dumped upon or just being left with a huge pile of tasks. So it keeps that responsibility there. Okay, next slide, please, Kim.
I think this is a little bit from me about supervision as well, Anne.
Thank you.
So we did here at the Health and Care Professionals Council with Newcastle University. We looked at supervision, exactly what Anne was saying, and I thought I'd share with you a few of the things that the report recommended. They're things that you'd expect. They're things like having an open, safe, supportive environment, and it sounds like our registrant and the support worker you've heard from, Katie, have an open and supportive and safe environment. It's got to be good quality supervision relationship, and there's got to be cultural awareness, sort of appreciation of the uniqueness of each of us, and there's time for quality feedback. Really, that's the important thing. And there are two types of supervision. It sounds like there's one-to-one or small group supervision, and that can be involved in lots of things, particularly on reflecting on individual clinical situations. And this is sort of your day-to-day supervision happens. And then there's peer supervision, where there's peers in the same organisation working together. And this is more of a reflective conversation, sharing views on collaboration, teamwork, and some important stuff about career planning, for example. So I thought it was really important to point out why supervision is so important. You know, it's about appreciating each other, and it increases job satisfaction, staff retention. It makes us as registrants and support workers feel confident. It's super important, and it develops our leadership skills. Makes for a better working environment and improved quality of care delivery. And there's lots of research to say that it reduces stress and anxiety. So really important. But we know there are barriers to effective clinical and peer supervision. You know, we know that there might be a lack of time, a lack of understanding about the importance of it, and all the contextual factors, for example, lack of time, lack of space to do supervision, and maybe the organisation isn't supportive, and indeed the supervisor hasn't got the skills and training and support. So that leads me to just look at what is best practice in supervision. And lots of people suggest that supervision generally, when you sit down and think about supervision, it should be at least 60 minutes, it should be regular, it should be at least monthly, but actually weekly would be even better. So that's the sort of things that we need to think about when we think about supervision. That's just some tips and hints. And the report that we commissioned said that effective clinical and peer supervision is based on 10 characteristics. Some of them I've already mentioned. Firstly, being trustful and respectful. It depends on the choice of supervisor, and there needs to be a shared understanding of different roles. And I think this webinar is exactly doing that, isn't it? It's sharing understanding between the registrant and support workers. It should be regular, based on individual needs, and obviously there should be protected time to undertake it. And supervisors should be trained. So I think that's really important. And I'm going to hand over to Sharon. Sharon Gadwell is the Assistant Director for AHPs at Kent Community Health NHS Foundation Trust. And I'm going to pass over to you, Sharon, just to look at what you're doing at your trust, but also more wider than that.
Thank you, Kim. Next slide, please. So just while waiting for the slide, I am going to talk a little bit about what we have in, I'll abbreviate it to KCHFT for ease of conversation, and what we've been developing over a period of time. So can I have the next slide, please, Kim? Thank you. And I'm really going to start from the very beginning. So what do we do to help ensure that we're supporting our support workers? And I think that at the very beginning, when we're recruiting support workers, we're making sure that within the job spec and person specification that we're clear on relevant qualifications that we're looking for. And that doesn't mean to say that we wouldn't support qualifications. I'll come on to that later, but we're just really trying to set a clear understanding of the skills that we're looking for from the outset. Some of our teams, so we have 750 registered staff in our organisation and 175 support workers. And within some of our teams where it's very, very clear what the expectation is over certain procedures, we will have standing operating procedures in place. And what that means is it's guidance on the way in which we would like support workers to deliver a certain aspect of care. So these are some of the things that could be very supportive when we recruit support workers, you know, from sort of the outset, some real understanding of what is expected. I think, as colleagues have said before, Katie, Ruth and Kim and Anna said, it's really important to understand the roles and responsibilities of the registrant, but also the support worker, and sort of set our intentions from sort of the beginning and working through that period of time when our support workers are relatively new. We also have in some of our teams preceptorships for our assistants, and that means that we have a designated programme of continuous professional development, some training or some shadowing, some time to ensure that over a period of time, and that might be 6 to 12 months, that the assistants and support workers, are getting exactly what they need with regard to support, with training and also competencies. We have the care certificate in our organisation that we have an expectation that people will complete, and we try and make sure that that sort of dovetails and complements what they're learning at the outset and the beginning of their roles. And this is all really to support what Ruth and Anne were saying about, and also Katie, about scope of practice, and making sure that we are supporting our support workers to have that scope of practice before we're delegating things that would be, or making sure that we're not delegating things out of that scope. Thinking more wider than my organisation, I think it's really important to mention this, is that in Kent and Medway, in the ICB is the Integrated Care Board, we also have resources for our support workers. So we work across our system, and we have a Padlet, which is a repository for certain pieces of information that support workers can access. In addition, we also have a Kent and Medway support worker peer support group, and that's across all providers within the system, and that's about 11 providers, and it's a Teams, on a Teams, and it's a support group that probably occurs, I think, is around every 6 weeks or so, where support workers from organisations can come together and really share best practice, support one another, and have any innovations or developments to really share that across the whole system. So I think that's really important as well, to be aware of that. We've heard a little bit from Anne with regard to professional bodies, and obviously each different AHP professional group has a professional body, and I think Gabby will make the NHSE HEE support worker resources available. There are some links to those documents, but again, they are all available to our support workers to access as and when. But it's important that we are highlighting their that they're available, and as appropriate. I wouldn't suggest right on day one that people want to know that, but as they develop in their career, there's some really useful resources. Can I have next slide, please, Kim? Thank you. So I think the presentations that have gone before mine have really set up some of the conversation that we have and some of the things we have in place, but competencies for us are really, really important. And I can see on some of the chat that some people were saying, how do I go about ensuring that I have competencies, and how do I progress with those? And this is where the registrant really comes in to understand the role that we're asking support workers to do in the different areas of our organisation, what competencies are required, and when it's appropriate to sign off the different levels of competencies. So I think this really is critical. It's not something that might happen in the first month or so. It might take a longer period of time, but that whole piece around what Kim was saying, when it's appropriate to delegate, really dovetails with signing off the competency. I've mentioned clinical supervision, and I know this has been talked about quite a bit, and I think it's really important to reiterate there's lots of ways of having supervision. So there's the formal and informal. We like to ensure that we're regularly meeting with our support workers. It also makes part of the appraisal process. So we have supervision regularly, but that can feed into the sort of 6-monthly review and the yearly appraisal process. And part of this process is potentially reviewing documentation. So I know it was mentioned before about how important record keeping is. We can have the clinical supervision sessions looking at documentation, looking at if there are any concerns, looking at how to escalate any concerns. And it's really, really important. And all of those 10 elements that Kim referred to, I think, are critical in making this really, really useful, productive, informative. But it is a real critical place and time to ensure that that doesn't get lost, and that there's time to continue the development of support workers. And in there we can have conversations about skills and scope of practice, and if there's any areas or any shadowing or anything like that, they can all happen in these clinical supervision. So they're really critical. In addition to that, looking at safe caseload numbers and caseload reviews. So again, there's many different roles within our organisation. Support workers may be profession specific, so supporting OTs or physios or speech and language therapists, or there may be supporting two professions. So again, it's really important that each registrant knows what the whole scope of that caseload is, and there are reviews on an ongoing basis. We do like also to ensure that our support workers have peer support, and so this may be, it might be the peer sort of support in a supervision type focus group, or it might be sort of, time out with a more experienced colleague. And that goes the same for coaching and also buddying. In one of our teams recently in our children's services, we've recruited quite a few support workers, and it's quite a new sort of opportunity and a new way of working. And so we're ensuring that the support workers who are more experienced buddy with those that had just come into post, so that they've got some real opportunities to sort of air some of their challenges perhaps and be reassured by the buddies. We offer training days for our support workers, and they can be numerous. It really depends on what's the scope and the competencies required and what specifics that the support workers need. And some of those training days will be offered as a team. So the registered staff and support workers will be there together, learning about a new skill or an update. In addition to training days, we do offer lots of apprenticeships. We offer the healthcare support worker apprenticeships and also the senior healthcare support worker apprenticeships and the assistant practitioner apprenticeships. And what's really lovely about our ability to offer all these apprenticeships, we have within our organisation an AHP Academy, and we do try and support our support workers to then, those who would like to become registrants. So we do ensure that we offer the ability to make sure they've done maths and English, as well as, whatever foundation level support apprenticeship they might need, and then progress to the HP careers. And at the moment, within our organisation, we have physio apprenticeships, occupational therapy apprenticeships and podiatry apprenticeships, and looking to bring on some of the other HP apprenticeships. So we're really trying to ensure that we have a really good career pathway for everybody. We're very, very fortunate as well in our organisation to have professional leads support, and I think one of my professional leads is actually on the call. So we have professional leads in the 5 of our the highest number of those AHP groups. And I absolutely think that the support workers as well as registered staff are supported by our professional leads. And in some cases there are support worker groups, but our professional leads do ensure that they're keeping an eye on our support workers and supporting them as well as the registrants. So that's another area of support. And we do offer action learning sets within our organisation as well. So I think there's some of the key elements that we have within our organisation, and I think it complements what's Kim and Anne and Ruth and Katie have said going before. So that's the end of my presentation. So I'd like to now pass over to Soraya, and she's the National Workforce Lead for Support Workforce Programme. And I think we're coming on to the Q&A section of our webinar. Thank you.
Thank you, Sharon. There's a good few questions that's come through the chat. So colleagues, I've been having a look at that and just pulling through some themes that's come through. So I'd like to invite Katie and Ruth, if you can put your camera back on, please, Katie and Ruth. There's quite a few questions that you'd be able to answer. People had a lot of interest in what you were talking about and how you'd achieve the model of working that you're doing. So they just wanted you to share a little bit more. So if I maybe bring some of those questions through first.
Yeah.
So Sammy Jo was asking, she's a SLT assistant, and she wanted to know, how did you start with your competencies? So to have an understanding of what was within your remit and what was without. So how did it start out for you?
Yeah. So at the QE we have quite a formal process initially. So Katie came and met with us as speech therapists, and there was some mixtures of face-to-face teaching, presentations, and going through a lot of the theory that underpins our role as a speech therapist, but at the appropriate level. And then we then had some face-to-face contact with patients, and there's a competency document that Katie has worked through. So in speech therapy, we can break it down into different areas. So there's one for swallowing, speech, voice, language, and we've taken it from there. So broken each area down into knowledge and skills. And then Katie has worked her way through each of those competencies. So it's quite clear from the outset what we would be expecting of Katie to be able to do by the time she could complete the competency document. There are some remits, so managing tracheostomies, managing and doing some of the dysphagia therapy and certain dysphagia assessments that would be outside of the scope of practice for Katie to do. And as in the case study that you've seen, the LaxVox voice therapy wouldn't be something that we would routinely get our assistants and support workers to do. But that doesn't mean that if it's things that are highlighted in appraisals and things that feel like they fit within the role and they're safe enough for patients and safe enough for support workers to do with the right supervision and teaching, that they aren't things that we can then look to expand upon. I don't know if you've got anything to add.
I think because of being in a specialist area as well, and this is how my role differs from other therapy assistants, because of working in quite a niche area and quite a specialist area, it's quite important working within the different specialities. But yeah, so definitely, because my background always has been initially physiotherapy and occupational therapy, so expanding my role to work with speech language and dietetics from, you know, a competency and a training point of view, yeah, really important to have really regular meetings, didn't we, initially? And, you know, the guys are great. If there's anything I'm not confident or competent with, they will always spend time and go through the training with me. That's appropriate.
Thank you. Kim, can I ask you maybe to stop sharing the slides for a minute so we can see our colleagues a bit better, if that's okay? Thank you. You can stay off mute, please. Katie and Ruth, there's a few more questions coming your way. As part of your competencies, do you as a Band 4 have any responsibilities for training others as part of your competency set?
For
that
training,
come from Natasha, yeah.
For training who, sorry? Other assistants?
I would assume it would be people that will be junior to yourself. So do you have any responsibilities for training anybody else as part of your competencies?
Yeah, so not necessarily as part of my, not as part of my competencies per se. We're a teaching hospital. We push for teaching and training of assistants all the time, and I think nationally we're trying to encourage support workers and assistants to develop within their roles. So me in particular, within Burns, I am the only therapy assistant. However, we do have a therapy support worker who her role differs slightly because she's employed by nursing with elements of therapy. So someone like that assistant, I will do some training with within the Burns area. More so to go through education about my role, to help her with developing with you know, going through range of movement exercises and things like that, but that would be more so with her supervisor. We do, as Ruth explained, we do have an assistant in training, in-service training program, which I'm part of the learning and development team. So myself, working with some other support workers and assistants and some of the registered professions, we actually look at doing a table where we do weekly or 2 weekly in-service training sessions, but that's from, you know, ourselves presenting or getting registered staff members or external speakers to come in and do training.
Okay, we just had another question pop up from Camilla in the chat box around the training element, just asking whether you actually deliver any training or support to AHP students that's on placement with you in your team.
So we, as an assistant, I wouldn't be involved with the training with students. However, we tend to have third year students mainly physiotherapy students on the burns unit and occupational therapy students. Speech and language obviously go with the team, they'll go to other areas. If it's an experienced, if it's a student that's a third year student and they're quite competent and their educator's happy for them to come along with myself and for them to lead a session, I will be their like assistant essentially, then yes, I will do that. But in terms of training them, no. But you know, I know students really value support workers, and they really value assistants because we are static members of the team usually. We are very experienced, so they do, you know, they do really appreciate our feedback, but we will always liaise with their educator, who is the registered staff member, to just give them some feedback really.
I think training is probably a very strong word in that scenario. It would be how, but you'd still be getting engaged and supporting them on placement, which I think is probably where the question was coming from. So not signing off their training, especially if they're in their final years, but more being that whole supportive package for that placement for that student, because you've got a wealth of information and experience in what it is that you do, and you've just clarified that is what you do. Thank you. There's been a few questions, and I'm not sure if you're able to answer this. It's around how big is a band 4 caseload, and I know it's dependent on the service and the speciality, but because it's been such a repeat of that question, just how do you kind of work out? Do you have a model of what it looks like for you in your service? And I think the answer you give people will have to take with a pinch of salt that it is to your service. How big does that band 4 caseload look?
Every day is different. No day is the same, as I'm sure most people in this webinar will say as well. I think, again, it is quite difficult when you are, you know, a lone ranger in the sense that I am the only therapy assistant within burns as a speciality. I do have to be quite good at prioritising my caseload. I do have to be quite good at speaking up and saying to the registered staff members, I haven't got time to do that today. However, you know, could they be bumped down to an amber, for example, or is there any chance I can prioritise that tomorrow? So I do have to look at my caseload. But as I say, every day is different. I think the more experience you get, and I'm very lucky within my team, I work with some, you know, fantastic registered staff members who really do appreciate that I work across 4 disciplines. And I think they can read from my facial expression sometimes that if it's too much, they know to back away. But, you know, they're very good at checking in with me and making sure I'm not overloaded. So I think the take-home message is, you know, speak to your supervisors, speak to the registered professionals at the end of the day. They're there to support us as assistants. And I think you'd agree with that, wouldn't you? Yeah.
The collaboration, isn't it? It's keep the communication going. No, that's fine. There was a lot of interest in your 6-weekly formal supervision model, but obviously you support multiple professions. So colleagues wanted to really understand what that looks like. So is it one professional that takes a lead on your formal supervision, or is it everybody together, or do you take it in turns? What does that look like for somebody working to support multiple professions?
So Katie has her formal 6-weekly supervision with her formal line manager and appraiser. So that's done through one profession. However, as the rest of the team supporting and working with Katie, we can then all input into that supervision. So if there's anything that we feel that needs feeding back or discussing or taking further, then we've got a named colleague who's a port of call for that, for Katie's 6-weekly formal supervision. However, we do really regularly catch up with Katie on the ward and do our ad hoc supervision with her around the caseload, around development. And Katie knows she can come and find us if we need to have a more formal speech therapy specific sit down and go through what's been going on. So I think it's been really flexible and not being too rigid about supervision with a role such as Katie's, because we know she's pulled in 4 different ways. We know she's trying to manage the patients from a really holistic point of view, but we know that for every patient that she's seeing, there's probably 4 of us going, oh, could you do this? Oh, could you do that? And that's a lot for somebody to juggle, as well as then putting in lots and lots of supervisions. Katie wouldn't actually have time to see any patients. So it's really around, again, that collaboration, noticing if there are things that we need to be discussing, Katie knowing that she can come to all of us and request that supervision if she feels as needed, but knowing that there is that 6-weekly supervision formally in the calendar as well. Do you agree?
Yeah.
So are you feeling comfortable if you're needing something more, if you've got a particular challenging situation, that you can go back and ask the registered clinician to provide an additional, but okay, no, that's great.
And like when it comes up to our appraisals, I actually send out what we call 360 forms. So it's like a good generic feedback form from everyone really, and I take that to my appraisal as well. So it's just to basically say how everyone thinks I'm doing as well.
Excellently. We had a question from Tom Wilkins. He really likes the model, and there was quite a few people that really liked the model of how you were working. But he wanted to understand a little bit from you both, what was the barriers and the enablers to setting up that model of working? And then he had a very specific question for you, Katie, as in, what is your job satisfaction like working across that multiple professions?
Should we do the model first?
Yeah. So I think the model of working came out over years really of development, of having assistants working on the burns units, and because it's such a specialist area and patients are on there for quite a while, it's a perfect setting for rehabilitation. And I think we can all appreciate the pressures, and actually having somebody who's competent, enthusiastic and really rehab focused is just incredible for our patients on there. So it seemed like quite a natural fit to then progress a role from, I think it was initially OT and physio assistant, and then progress to then having elements of speech therapy and dietetics in it as well, because of the caseload. Really, that's what really drives it. There are other areas in the hospital that have band 4 therapists, but I think there's been another therapist that's OT and SLT, and previously OT and speech. But again, I think it's quite unusual to have one that's all 4 disciplines at band 4 level.
And job satisfaction. Wow. I've just should have linked the TikTok video I did recently, actually.
I was thinking of that.
I've been an assistant for a very long time, and as I'm sure many assistants who are on this webinar, when you get up to that band 4 level, you kind of hit the ceiling really as to where you can go in terms of like your career pathway. So one of the reasons that burns took a particular interest to me was because of working for the 4 AHPs, because that's not something I've ever done before, and it's quite a niche role, as I'm sure everyone would agree with. The cohort of patients we get, as Rue said, some of them are with us for a very, very long time. So seeing a patient from the very early acute stage, from as early as ITU, all the way up until they go home, being someone who is a full-time member of staff, who has that regular involvement, taking that holistic approach, I get great satisfaction from that job, because you build such a rapport with that patient. And as as we can all appreciate, that the guys, the registered staff members, are so busy with, if they've got poorly patients or patients they need to prioritise, me being that go-to who's able to continue with their rehab, it's just amazing to feed back, actually, yes, this patient's progressed really well, and actually, no, I think they need a bit more input from a registered point of view. It's such a rewarding job. Like, I absolutely love it. I can't be any more enthusiastic about it, really. It's really, really good. I love it.
No, it does come across. And this is something sort of in a similar vein, but a colleague was just asking from yourself, Kate, what is your professional identity? Now, you've described how you work and your passion for this work. So I would assume there isn't a particular challenge for you, but you just wanted to know how you identify professionally. And then from sort of Ruth's perspective, if you've got a colleague that's working across multiple professions, if you're looking at supporting their career progression, and say if with Katie working as a band 4 and she wants to progress, and you're looking at maybe a registered profession, how do you support her? How do you help her in that decision making to choose one out of the 4? So if I come to you first around the professional identity, Katie.
This is why you know, I always have to refer myself as a therapy assistant. I think nationally this is a bit of a taboo subject, because I think as assistants we're trying to have that umbrella term for what we all are, because some people are called support workers and some people are therapy assistants, physio assistant. You know, we're just like, we need that you know, that name for what identifies us. As you can imagine, I have all the 4 registered professions saying you should be a physio, you should be an OT, you should be speech and language. Truthfully, at this point in time, I'm quite happy with the job role that I'm in at the moment. There was a time where I always wanted to be a physio. There was a time I wanted to be an occupational therapist. I had a meeting with my dietitian, the senior, the other day, and she was saying you'd be a good dietitian, but there's too much maths involved with that. However, currently, I'm really happy within my role. Whether there's scope in the future for any more development within my role, who knows? So how I identify myself is as a therapy assistant, and I'm quite happy with that at the moment.
Thank you, Katie.
I think as registered staff supporting and working with assistants, I think we're always mindful that we want to be progressing and developing and maximising all the wonderful potential that our assistant colleagues have. But I think we're also very aware that we all say to Katie, you would be a great this, you'd be a great that, and really letting the assistant come to us. I think we like to support, but maybe not be too pushy. But the great thing about AHPs is that we all have so many transferable skills. So I feel like actually it's not I don't know, we're not fighting for you, Katie, no. But we're going to be supportive, yeah, and know that actually if you did want to go off and be an OT, that we'd all be right behind you, and the development continues no matter what. But as I say, the transferable skills between the AHPs are huge, and that's what actually really helps with having that role sit with one person, because we get assurances from all the MDT members, all the people that you support, of the level that you're working at and the excellent service you're able to provide our patients. So yeah, I don't think about questions.
No, it's good to hear that you supported, and in essence the decision is going to be yours, Katie, which one of them you choose, but it's knowing that you supported in any one of those directions that you're wanting to go. But you're right, you make the call as to what's right for you, and you're doing a fab job at the moment, and if that's what's making you happy and giving you the job satisfaction, then all kudos to you. That's great. I'm going to give you a break. You can have a drink of water, but if I invite Sharon to come back on screen, please, Sharon. I've got a couple of questions come through for you. We've had Sammy Joe asking, as well as the preceptorship was a really fab idea. A lot of people really liked the thought of having preceptorship for the non-registered workforce as well, but just really wanted some advice on how did you actually start that preceptorship program for your non-registered workforce?
So I don't know if this is possible. So Wendy Winpenny, who's actually on the call, is our professional lead in podiatry. And
there she is.
Wendy, you'd be far better. Can we unmute Wendy or not?
Gabby, are you able to unmute Wendy?
Yeah, done.
Yeah, you can unmute.
Brilliant. I will hand to Wendy because I would be stealing her thunder. She's the one who did this. So she'll be able to give you a better overview. I'll mute myself.
Thank you.
Okay.
Wendy, are you? We can't see you, but we can hear you now.
No, my camera's been turned off for some reason. So.
Oh, bless you.
But I think it's your end that my camera's disappeared from. But anyway,
we'll try. But if we can hear you, if you want to carry on, and we'll try and work on the camera.
Okay. So there we are. So we have a number of posts suddenly came out for band 3, so we had quite a few, and it just became apparent that they were all going to be starting together, and it was a really nice opportunity for us to actually sync their development and learning together, because previously it was a very historical role where people stayed in that role for a very long time, whereas we had the opportunity to change. So we've put together a document which is a month-by-month document that says within the first month you will be shadowing, for the second month you will be going into a different skill, going into nail surgery, and then you need to be peer reviewed and you need to be signed off. So each time you have something new within a skill, that there's a competency and a signing off process attached to it, and that you can't carry on with that pathway of development until you've actually been signed off as competent. And we find that has really helped. And also, one thing that we do within our service, which I am incredibly proud of, is that when we have any new band 3, when we advertise and we interview, we make it very clear that this is actually what we would like is a development role. So we are really happy to develop you. The trust, as Sharon said, will support you through your maths and English. We will then support you through your level 5 apprenticeship. And now we've got 2 of our band 4s, which are actually doing their level 6 podiatry apprenticeship. And that preceptorship document starts their actual development journey.
And how long does that preceptorship program last? Is it a set length of time? And do you kind of bring the different AHPs together, or is it just profession specific done within their own base, but they follow preceptorship period?
It is just within podiatry. I have it for a year, but everyone works at their own base, not base level. We've had a band 3 who came to us, who has flown and came with an awful lot of experience, so hasn't had a year's worth of development. So it's there to sort of support them and also to make sure that they can hold us accountable, that we are actually providing what is needed and we're not running away with ourselves and thinking, oh, we really need them to do this for ourselves. So it actually sort of staggers us as well, which is good.
I've got one more question which you might be able to answer, or Sharon. Sarah Simmons was asking, have you got a process where if you've got a band 4 who's not meeting their competencies, do you have a process that you follow to address that?
Yeah. Wendy, you want to pick out Wendy?
Yeah, so our competencies are, each band has a competency document, and the process would be peer review, support, sitting into clinics, the normal thing that you would do with any clinician, any registered clinician who was struggling. You would give them tons and tons of support and guidelines and just the areas that we need to support them on.
Thank you. I know there's been a lot of chat going on since we started the Q&A, so if I'll just come to all our panel members, is there any key themes that you've seen in the last few minutes that you wanted to bring any question into the panel? Or otherwise, I'll open up the floor to anybody that wanted to raise a question that's not been covered yet. If you wanted to pop your hand up, and then we'll be able to bring you in.
Sarah, sorry.
Oh, sorry, go on, Kim.
Apologies, Sarah. I was just wondered if I could ask Anne to have a think about, a lot of people are talking about countersigning, and I know that she's got some, the HCPC guidance is quite high level and talks about delegation and responsibility. It doesn't specifically talk about countersigning records of a support worker. I wondered if somebody had already asked that in the chat.
Yeah, there's been a couple of questions about that, and I've put the link to our keeping records guidance. So this would be for occupational therapists. So I mean, I've been an OT for quite a long time now. So I qualified in '94, and when I was training, and at that time you had to countersign student notes and support workers' notes, but that changed a long time ago. But there's still the expectation in some places that notes have to be countersigned. But there's nothing from HCPC that says they have to, and there's nothing from the Royal College of Occupational Therapists to say that as well. And I'm sure the other professional bodies would be very similar, but sometimes it is local policy. So you might have to check your local policy and your employer to see what they say, but there's no expectation from the regulator to countersign notes. It will come under the same criteria, in that you would only delegate notes to somebody you feel is competent to do it, and that you retain responsibility for what is written in those notes. So it's the same principles.
I would echo that, Anne, because it is very much down to local organisation. It's down to what the organisation has within their government that they've got, delegation, supervision. They've got, caseload review. They've got all those mechanisms in place where they're providing that ongoing support to avoid any particular challenging situation. So they're quite assured, and that process gives assurance to the organisations, and that's where they may not require the countersigning. So it is very much trust dependent. But like you said, you've got to ask the question back at base, but it is dependent on your governance framework of how you provide that assurance that all those mechanisms are there to make sure things are safe and effective. Thank you, Anne. I've got Samantha Bradney, who's put your hand up. Gabby, if you can please unmute, and Samantha can pose a question. We can see you now, Samantha.
Yeah. Hello. I asked a question quite early on in this today about moving from a band 4 to a band 5 without going to university. I've worked at a band 4 level for 13 years, and the apprenticeship stopped. I did a physio assistant diploma, and it was my access into university when I was 41, and now that access doesn't allow me in. I need my maths, which I haven't got. I did go to university, to college a couple of years ago to start my maths, but it stressed me out quite somewhat. I don't know what it is. I can't get it. So for me, moving forward at 53 years old, is there anything out there that could move me from a band 4 to a band 5 without going to university, basically?
Gabby and I will be able to share some anecdotal examples from what we've seen within the program, but if I open that up to anybody on the panel that might want to answer.
Right.
I'll start, Gabby, and you might. Obviously, we're talking about from what we've seen, Samantha, from within the program, what's come through. So where we've had colleagues that have, because HEE doesn't dictate what the banding of a role is. That's very much down to the trust, because the trust will look at what roles are needed in what particular service pathway, and that's where the job description is created, and that job description is then goes to agenda for change, panel, matching, and that's where the banding is set. So from the work that we've done within our framework was very much looking at the clinical part to start getting some standardization for those entry roles in and those progressions. And if you're looking at those progressions to university, we're working a lot on trying to create the opportunities for apprenticeships, but that's not what you're wanting to do. You're looking at the alternate. So what we've seen from colleagues working in support workforce roles is that they've looked at beyond the clinical. Sometimes they've gone into clinical and management, so operational management of colleagues, depending on what your service needs, on how big the workforce is. Others have worked into research, some have gone into education. And we do have some support workforce colleagues that have gone into sort of more leadership roles. So with this project that they've done for us, they've stepped into project lead roles to look at the funding that HEE provided was for trust to really get an understanding of what they had in terms of support workforce. And a lot of trusts looked at getting non-registered staff as part of that project team, so they stepped up into higher bands doing that, and for some of them it's led into further leadership roles within the faculty, within the system. So that's been our experience over the last 18 months, but it is very much down to within your organization. So it's having that career conversation with whoever your supervisor is, but also looking at what the framework is telling you, and Gabby did put that into the chat box as well. And so that you can ensure that conversation is sort of rich for you within the framework of your organization. But there's a lot of opportunities now, but each trust, it's not a mandated situation. It's very much dependent on trust needs and how the roles have been. There's more the variety, or shall I say the variability in the roles are less. So there's better understanding and how they can bring the roles into new models of care. And that's where the non-registered workforce has been able to grow. But I'll bring Gabby into. Gabby, did you want to add anything?
No, I think you've probably just covered it. Most of our kind of scoping work around Band 5 roles have revealed that it's the non-clinical stuff that people have developed, and that's what's differentiated the band 4 to the band 5, but as Soraya said, that's very much on a local basis, trust by trust. So I think it's really crucial to have a good quality career conversation to sort of set your ambition that that's where you'd like to go, and look at what those non-clinical areas could be that you could push into. So operational management, I know one, Emma Busby, who's joined us on previous webinars, she's now stepped into that, but that has been via an apprenticeship route. So she has gone to uni and done an apprenticeship route to enable that. That doesn't mean you have to do that, but you know that there are lots of opportunities. It's finding out what is available to you and what's right for you. But I don't know, Anne, you came on camera, so I wasn't sure if you wanted to add something in there, Anne Keane.
Yeah. No, I was just going to say, if it was anybody, it'd be good as well to contact the CSP. Charter Society of Physiotherapy.
Oh yes.
There's nothing from the panel that would have that particular expertise. Oh, Daniel, or Dan, he's waving at us.
Daniel, did you want to come in to add to Samantha's answer, or did you have a different question? Both previous. All right. Is that okay, Anne? Is anything more to add? Otherwise, I'll bring Daniel in.
No.
Over to you, Daniel. Thank you.
Thank you. Sorry, it's just because of Samantha's question. I work as one of the senior physios for a community interest company down in Surrey, and basically we run a community cardiac service. For example, we had quite a large number of what we term clinical exercise specialists. And by doing the BA CPR course, one of them actually secured a cardiac specific band 5 role. So echoing what's been said, you can progress from a band 4 into a band 5 role, but it is very much dependent on specific skills to a given role.
Yes.
And actually we have got a large influx recently of people that are working on kind of apprenticeship style schemes. So they must be out there. Obviously, you're working quite far up north compared to where Surrey is. But I mean, there must be opportunities linked with local universities, that local trusts and things could maybe look into creating partnerships and developing partnerships. So, I mean, the roles must be out there.
They must be. I agree.
Finding them.
That's right. I've got a supervision booked in April, so I am really going to start pushing for this now, because I feel like I've been here and I'm at a dead end, and it's quite frustrating.
Yeah, and I don't know whether if it's written into your PDR and things like that, then obviously it kind of helps guide direction towards what your ultimate end goal is.
Yeah.
But yeah, there are things out there.
All right. Thanks, guys. Thank you so much, everyone.
No, that's fine. It's just one more thing, Samantha.
Oh, sorry. Yes.
There's community of practice has been established, so it's a national community of practice for our non-registered workforce. I know Luke Capon has been. I think he runs the forum, but we can always, if we'll put our generic email address in the chat box, and then maybe just drop us an email, and we can link you in with him. Because I think
what was his name again? Sorry,
Luke Capon, Capon. Because there you can be able to have that conversation with colleagues that's looking at networking as non-registered colleagues, but then also being more aware of what the opportunities are, because you're not asking for your banding to change, you're looking for that next opportunity that you can apply for. So it's seeing where those opportunities are. And did you want to come in again?
Yeah, thank you. I was just going to say, and you just mentioned it as well, but for Samantha and anybody else on the call as well, people have also got the right, where appropriate, to look at rebranding, to request rebranding, and people to look, obviously to look at people's job role, and also if you're a member of a union as well, they can help you with that. So yeah, that's always an option as well, if that's appropriate for people's circumstances. So that could be good to do that.
Thank you very much, Anne. Thank you.
Thank you.
All right.
Thanks, guys.
Okay, thank you. I'm going to bring one more question in, and then we're going to have to bring the webinar to a close. Julie, would you like to come in? Gabby, have you taken Julie off it, or she disappeared on me now? Oh, there we go. There you are, Julie. We can't hear you yet.
Sorry, I can't find Julie. Have you got your hand up, Julie?
Pop your hand up again because it will just highlight you because it just, there you go.
And I can find you. Thank you. Yeah.
Just unmute and then
Thank you.
good to go. There you go.
Thank you very much. It was just on the back of what Samantha, just for a bit more guidance for you. So I work for LCH and we're in the midway stages, I guess, of launching the higher scope work stream for our TAPs, which are our therapy assistant practitioners, so our support workers. One of the things we're looking at in the trust, it's not in place yet, but we're looking at developing a advanced practitioner role, which would be a band 5, which we're looking at. It would obviously be competency based, but it wouldn't require university degree standard. I don't know whether Samantha, that would be something you could look at suggesting in your trust, or maybe doing a bit of a business plan for it. Yeah, it's just something.
I have looked at going to university 12, 13 years ago, and then they stopped the apprenticeships, and then they rebought them out. Yeah. And I was 50, and I'd got to get my maths, and I struggled. I struggled massively. It caused me quite a lot of stress. I've now got grandchildren. You know, the time when I wanted to do it, my children had just sort of got to their age, and so that would have been ideal. Apprenticeships all stopped. Now it's reopened. I've got to have my maths, and it caused me quite some stress. And at 53, do I want to go and do a 4-year university degree? And do you know what I mean?
Yeah, the role that we're currently introducing or hoping to introduce it's to mirror, I can't remember what trust it is, but they actually have an advanced support worker post, which doesn't require the degree element of things, but it is a support worker in a band 5 position.
Yeah.
So it might be something that you have a little bit of. I'm in Leeds, so it's Yorkshire. So it might be something you have a little look into. I'm not sure what trust it is that offers it, but it's something we are looking to offer. And because we just recently introduced the band 5, which is for a registered member of staff, but we've just introduced the band 5 to 6 development roles for the physios, and we're looking at expanding our career progression pathway for support workers. So feel free to drop me a line or whatever. I'll try and find out a bit more info, but it's something we're looking to offer.
Okay, Julie, thank you so much.
Thank you, Samantha.
No problem.
Cheers. Bye-bye.
Gabby, I'm going to hand back to you, but we've got one more question from Katie. Are we able to bring Katie in, or we're running out of time?
Yeah, we're running out of time, I'm afraid. Katie, if we drop our generic email into the chat box, then please do. Yeah, brilliant. Just contact us and then we can answer your question. I'm really sorry. I'm just conscious we've only got 4 minutes left. So if you can have the slides back up, please, Kim, that'd be brilliant. Thank you. Again, if we haven't managed to answer all your questions, I'm really sorry. There was we've had over 1,000 of you join today, which is absolutely brilliant. Get in touch with us via that generic inbox and we will answer your questions that way. So here is just some additional support. We've heard about lots of support that's available from you guys providing it and sharing through the chat box, which has been fantastic. Also through Anne Keane at ARCOT and Kim from the HCPC. Here's some additional support from some of our other AHP professional bodies that they wanted us to signpost you to. I have put some of that in the chat box. There is considerable amount of work going on with our professional bodies, so please do watch out for further resources. I know there is more coming down the track. So next steps. Here are the next steps for us in the National HE Support Workforce Programme team. Watch out for the curation document, which I mentioned earlier on, and planning to be published early next financial year. Our next steps around supervision and delegation are really being shaped by our Commission stakeholder engagement project that I mentioned has been going on in the Northwest. Again, once we receive those recommendations, then we can shape our future activity. And on to the next slide, please, Kim. Then we just put together some suggested next steps for all of us here. So please do share what you've heard today and the key messages that you feel are needed to be heard within your teams and your colleagues. If your local supervision and delegation policies and processes haven't been reviewed for a while, then it might be worth checking those. Connect, because I know there have been connections made via the chat box. Please do follow that up. Ensure your AHP support workforce are really at the heart of your work around this, inclusively engage with them. And as you've heard today and can see from all the slides, there is information and resources to support, so please do access them and reach out. Next slide, please. So now's the time to go to Menti again. Just for some quick feedback, if you could just scan that QR code. It's only 6 questions, so it's the same question that we had at the beginning of the webinar, and we're just asking it again to see whether your understanding has improved or got better, or a better breadth of understanding around this. Just going to give you 1 minute, if that's okay, to complete that now. If you can't scan the QR code, then the code's there. You just go to menti.com. And then if we just move on to the next slide, Kim, please. And this next slide has just got our contact details and that generic email address, which I know we've had in the chat box, but again, if you need it again, and the web page link as well. And final slide, please. Which just leaves me to say a final thank you. Thank you to all the presenters today, bringing your thoughtful insights. Thank you to you asking some absolutely brilliant questions and for the great discussion. Thank you to those that were brave enough to come on camera, and thank you, Samantha, for your question. And a huge thank you, just for joining us and taking the time out from what we know is a very busy and highly pressured time at the moment. So take care and hope to see you all very soon. Bye-bye.